Well, now we're going to switch gears just a little bit and talk more specifically about differential diagnosis. We have to ask ourselves this question first, how can we recognize childhood apraxia of speech given that these children come to us with many co-occurring inefficiencies, if you will, in neural processing? So we have to, first of all, consider a number of things such as the medical history, the developmental history, issues related to their speech and language development, issues related to how much therapy they've had and when and what kind of progress did they make. The most important thing we do, however, when we're trying to come to a differential diagnosis, when we're trying to decide if we recognize any characteristics that we associate with childhood apraxia of speech, is that we make observations. This is what we do in all assessment, isn't it? We make observations. We make behavioral observations that are both speech and non-speech. Speech characteristics probably being the most important. And then we compare those characteristics with those commonly accepted characteristics related to any particular label. So for example, children that have phonologic impairment, the characteristics we typically associate with that are predictable, developmental, and consistent sound substitutions, or processes that can be identified, such as fronting, final consonant deletion, cluster reduction, typically produced in a fairly consistent fashion until they've been in therapy a while and begin to generalize. We make these observations across contexts. We're making observations while we talk to the child. We make observations during testing. So we have typical language, speech, cognitive assessments that are in our toolbox as SLPs. I'm going to be talking a lot about the importance of a motor speech exam when we're looking for the possibility of a motor speech disorder, and I will be making the argument for dynamic assessment. Now, testing isn't always standardized, and it certainly isn't always normed. For example, a standardized test is one that is specified as to what you do and how you score, and you do it the same way each time. It may or may not be normed. A normative test is one that's been given to many children across a broad spectrum, and then the scores of any particular child are compared to that larger sample. Well, sometimes, lots of times, we want to know where a child performs in relation to a big sample of children their age. Other times, we're more concerned about comparing or looking at that child's ability to do very particular processing related to that level of processing. It'd be like taking a test. This is called criterion referenced. If you're in school and you study and you're going to take your, let's say your undergrad speech and hearing anatomy course, and it's time for the final, that test is criterion referenced. That is, you're not looking at your score relative to everybody that's ever taken that class. You're looking at that score relative to how much of that information you knew. So some of the testing that we do is criterion referenced. Some of it may be normative. Some of it may be standardized, and some of it is not. Some of it is just the observations we make in our interaction with the kids. Here's an example of a speech protocol for children that will help you determine whether or not that child has characteristics of apraxia of speech. So first, we do a language sample. We do this with most of the kids we see, don't we? Especially the younger kids or kids that have more severe speech impairment. So we do this language sample in free play where we make observations based on whatever the child happens to bring up or say or produce. But we might want to get more information, so we might also choose to do some structured play. So I have this box with very particular toys in it that represent certain movement gestures that I want to see how they try to say. So I might have a dad or a dada, whatever the child says, or whatever I model, and see if I can get them to say, a mom, a baby, a puppy, other items that might be easy, especially if we're talking about kids that are not quite verbal or low verbal. but varied in their vowel content and syllable shape. So that would still be in a play format, but here I have items that I've picked particularly to try and elicit in a play format. This allows me then to make observations regarding phonemic and phonetic inventories and look and see whether or not I also notice any apraxia of speech characteristics. Next, we can, if the child's able, do a test of articulation or phonology. And of course, that helps us examine where the child is in terms of their phonologic skill development. We almost always do a structural functional examination, at least in our clinical thinking. Most of the time, many times, we don't have to sit with a tongue depressor and a stopwatch and actually have them do all these things that we learn to look for in a structural functional exam, often called oral peripheral exams, because we can see that the child has normal range of motion, strength, and speed just in the way that they're talking, just in the way that you've seen them chew and eat. We know that all the structures are fine. But maybe we aren't sure about that, in which case we'll do a more formal structural functional exam, and that helps us determine or rule out the probability of a dysarthria. Now, it's at this point in the assessment, because this is the only thing we do that's in a non-speech context, is when I'll test nonverbal oral apraxia as well. And usually I'll just have the child, I'll have a few items next to me, usually some kind of a doll, or if mom's there, I might just say, give your mom a kiss on her cheek, and see how they do that. I might have something they can blow on. I'll have them imitate me, go, or even if they're having a lot of trouble, just say, see if they can imitate versus, so that you get a sense of how well can they specify movement for a nonverbal but oral volitional movement. And next is the motor speech exam, and I'll be talking about this at some length. You know, we've used motor speech exams for years in adults, but rarely has it been talked about for use in children. And I want to argue strongly that, well, at least in my clinical practice, in my hands, the motor speech exam is the most important tool that I have had to help me distinguish whether or not and to what degree a child might have characteristics of apraxia of speech. So this purpose for the motor speech exam is to make further judgments regarding the presence and also the severity of CAS characteristics. Now, there are a lot of characteristics that children with childhood apraxia of speech, especially on the more severe end, a lot of characteristics that we will see that are not necessarily discriminative. That is, we might see them, but would also see them in children who have phonologic impairment, just delayed speech. So what are some of those? First of all, a limited consonant and vowel repertoire. Later I'll be talking about some children just don't have yet the imitative skill or the ability yet to try enough imitation that we can make a determination. So about whether or not there are characteristics of CAS. And in those cases, we have to just note whether or not there are any red flags. One of those red flags for younger or nonverbal children might be a very limited consonant and vowel repertoire. That alone, though, isn't discriminative, but it's part of the history, the early history that's very important, or in your observations, that would be a red flag. The use of simple syllable shapes. You see that in CAS, but it's not necessarily discriminative. You might see it in other cases too. Frequent omission of sounds. Numerous errors, that is, very poor standard scores on an articulation test. And poor intelligibility. Well, children with all types of speech sound disorders might make numerous errors, so that isn't discriminative. Children with phonologic errors, though, are likely to make more predictable sound substitution errors. But any child with a severe speech sound disorder, whether they have CAS, phonologic impairment, and/or dysarthria, may show poor intelligibility. So intelligibility alone doesn't warrant a diagnosis of CAS. A child with significant CAS is likely to have poor intelligibility, but it's not necessarily discriminative. So what characteristics are likely to be more discriminative? When we think about these more discriminative characteristics, we want to think about the fact that children with childhood apraxia frequently exhibit these characteristics, and relatively they're seen less often in children with other speech sound disorders. Remember, it's never black or white. We're talking about relative frequency here. So the first one, difficulty moving from one articulatory configuration to another. So this includes getting into an initial articulatory configuration and then moving smoothly through the syllable without awkwardness or halting or inaccurate movement. And we'll be seeing examples of that in just a few minutes. In this case, though, the movements may be clumsy, awkward, and the child may actually pause sometimes in the middle of this attempt at a continuous gestural accurate movement. Groping and or trial and error behavior. This is one that's argued about a lot, both in adults and children. And I think that the way to think about it is context. If you just listen to what a child does spontaneously, you may not see any groping, trial and error behavior. They're going to say what they can say. But if you're doing a motor speech exam or even in play trying to elicit a particular production, syllable sequence, syllable shape that they've never been successful at, you might see them if they put attention toward trying, usually only with cueing, you will see that groping. And we'll look at examples of that in a moment. So that's typically seen in elicited versus spontaneous productions. And the presence of vowel distortions. These are not substitution errors, but really distortions because the vocal tract shape isn't quite right, because the specification of the range of motion, or most typically the range of motion, but could also be the speed of the movement or the timing, so that the spatial temporal target isn't quite right, and you hear a distortion of the sound of the vowel. Prosodic errors, these are very often associated with childhood apraxia of speech. You might see lexical stress errors where instead of baby, they might say baby. But more often, you're going to see equal stress and segmentation. Baby. Inconsistent voicing errors. These are usually due to mistiming, where the voice onset time is in that gray area of categorical perception. So you aren't sure if you heard a P or a B. So those kinds of voicing errors are different than just always using a voiced cognate. Now I'd like to play, now that we've gone over these characteristics of childhood apraxia of speech, I want to say that kids with apraxia of speech don't all look the same, because apraxia can occur with a lot of phonologic impairment, a little phonologic impairment, a lot of language impairment, a little language impairment. The praxis deficits itself, the efficiency of the processing may be severely impaired, moderately impaired, mildly impaired. All those things make a difference when you're making observations about the characteristics. So I want to show you a few children with CAS at different levels of severity. I'll be playing a videotape, and we're going to see 3 different children. And what I'd like you to do is listen to the whole segment for each child, and then I'll pause it, and I'll make some comments about that child. And then we'll play the second child. You'll watch the whole thing, and I'll make some comments after that child. In your slides, I've put the segment or the link for where these examples can be found on the internet. Some children do have very severe difficulty with praxis or planning these movements, and will have a very difficult time learning to talk. Other children, though, may have moderate to more mild motoric difficulties and will need less frequent or won't be in therapy quite as long. It's sort of like coordination, where it's on a continuum, where some people have very severe problems with speech praxis and others have very little difficulty. The following examples can show you some of the variation in severity in childhood apraxia. The following examples are from evaluations and are not examples of therapy. This clip shows word repetition during an evaluation. Again, we're not providing therapy here, but just examining speech characteristics as he tries to repeat. Notice the inaccurate movements resulting in sound distortions. Good job. Bye. Up.
Up.
Moo. Dad.
Dad.
Home. Out. Out. Last clip, you saw a child with more severe apraxia of speech who also has trouble watching the clinician, which is something we worked on very hard early in therapy. You notice that I was over-exaggerating some of my movements and my volume and my prosody, only because that kept him a little more engaged than when I didn't. And I found that he would try a little harder to imitate what I was saying if I did that. It isn't necessarily something you want to do a lot in therapy, although early in therapy with him, we did do that. Now we'll turn to another child with severe apraxia of speech. In this clip, you'll see me saying some words, and he's repeating. These are quick probes that I'm doing just to look at his progress on some stimuli that we've been working on for a little while. After that, you'll see a little bit of his spontaneous speech. We'll be watching this child a lot more later in the course when we are showing examples of therapy.
Knee.
No.
No.
Hi.
Hi.
Use your breath.
Hi.
Good. Mom.
Mom.
Me.
Me.
My.
Bye.
Hi, Mom.
Hi, Mom.
My knee.
Me.
Oh, no.
No. Oh, no.
Good job. Very good. And how old are you? Good job. This child was actually not 3, but he couldn't say the word 5, and he tended to refer back to when he was 3. I'm not sure why he did that. But this was our first experience with this child, who had been in therapy with us for only a few weeks at that time. The spontaneous utterances you heard toward the end of that clip showed what he typically would say when we first met him. The words that he was saying at the beginning were words that had all been trained for at least a few weeks at this point, showing that he really made rapid gains, even though he had been in therapy for quite some time in his home community. This was likely because he was seen very infrequently, as he lived in a very rural area and did not get much practice in speech. This next child also has a severe apraxia of speech, but you'll notice that he's wearing bilateral hearing aids. This is an older tape, but I like to play it because this child exhibits all of the characteristics of childhood apraxia, but also is a good example of how these children come to us with more than one problem. So this child has hearing impairment. He has some intellectual deficits. He has a significant apraxia of speech and, of course, language impairment. However, this child is easily able to attend to the examiner, eager and able to attempt direct imitation, benefits from cueing, and actually did quite well in learning to speak. In this next clip, you will see a child who exhibits a number of characteristics of childhood apraxia, including groping for sound positions and off-target movements that distort sounds. Notice how he is inconsistent over repeated tries at the same word. Toward the end of the clip, notice how he does better if he's looking at the clinician's face.
Hi. Popeye. Two. Day. Dad. Very good. No. No. Nana. Key. Go. Now say I. What's this? I. Say ow. Ow. Up. 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 There you go. Very good. Say it again. Look at me. Say up. There you go. Do it again. Up. Do it again. Do it again. All right. Keep that right there.
In that last clip, you probably noticed that whenever he looked at Joe, he was much closer to correct production. This is a good example of how important having the child watch your movements is. We'll be talking more about that when we get to the therapy portion of this video. But I want to mention it now because it's not something we typically do. We have a tendency in speech pathology to use games and pictures, especially pictures, that take their attention away from your face. Not that that's wrong, but for children that have significant problems with apraxia of speech, it's less efficient because watching your movements is really the most salient cue. This next example is one of more mild to moderate childhood apraxia of speech. I'll let you watch the clip and then we'll discuss it a bit. In this next clip, you will see more probe testing where we are looking at the child's ability to say the phrases on which he has been working. Notice his deliberate manner of speaking, his slower rate, and the concentration he needs to use. He will need to use less concentration as the movement accuracy becomes more automatic with continued practice. I sit on, oh, whose turn? My turn. I sit on my bed.
I sit on my bed.
Bed. I need my Ben 10.
I need my Ben 10.
Oh, I heard all those good sounds. I won't fight.
I won't fight.
Good job. Look at me over here. I will have fun.
I have fun.
Let's try that again. Watch Edie.
I will.
Watch Edie. I will have fun.
I will have fun.
How about this one? I write with my pen.
I write with my pen.
You probably noticed in that last clip that there were many words embedded in sentences that had vowels such as eh and ith. Those are very difficult to treat in childhood apraxia because the vocal tract shape has to be just right. Although this child was more moderate in severity and responded very well to cueing, it was important for us to embed these words in longer sentences very quickly because although he could do them well in isolated words, they tended to fall apart as we increase the complexity of the motor planning. We'll talk a lot about choosing stimuli and why we make certain choices in our stimulus sets as we move along today. This last clip was also a really good example of how important it is to work on automaticity. Children with apraxia of speech may be able to achieve accurate movement gestures, but then generalization can be tough. And this is where the principles of motor learning come in. These principles help us make clinical decisions and treatment planning in terms of organizing treatment and providing feedback that allow or facilitate generalization. I just want to bring it up now, although we're going to talk about it in more detail in a little bit. The next clip you'll see is of a child that's probably more common for us to see, and this is a child with primarily a phonologic impairment, but he also exhibits a number of characteristics of childhood apraxia. So he would be given the label, if you will, of phonologic impairment or moderate phonologic impairment with a more mild contribution of childhood apraxia of speech. As you listen to this clip, try and distinguish for yourself, or perhaps even jot down, the characteristics that you hear that you would associate with a phonologic problem versus those characteristics that we would associate more with a childhood apraxia of speech.
In this clip, you will see the child naming some pictures and talking with the clinician. Note that he has some typical developmental sound errors, such as substituting T for K and D for G, as well as difficulty with the R sound. We call these phonologic errors, and they are not associated with difficulty with movement planning. These errors are consistent in that he always does them the same way. However, he also exhibits some sound distortions and slower and more deliberate speech, which is often seen in children with childhood apraxia. Many children with apraxia also make developmental or phonologic errors.
Hey, can you tell me what these are? What is this?
A house.
Good job. What's this part of the house?
A roof.
This is the roof, and this is, you look out the
Window.
Good job. What's this?
A tree.
Good job. What's this?
A phone.
What's the long name for it? Is it a telephone?
Yup.
Can you tell me that?
Telephone.
Good job. This is a
Teacup.
teacup. That's right. It is a teacup.
I have some yuckies in my ear.
You have some yuckies in your ear? What happened?
Doctor had it. I was playing in the swimming pool last night.
You were playing in the swimming pool last night?
Yup. And Daddy hit my foot.
Daddy hit your foot?
No.
What is?
Dalton.
Oh, Dalton. Is that your brother?
Yeah.
Yeah, Dalton hit your foot. Well, tell me what you were doing.
Playing on the blue slide.
Oh, playing on the blue slide. What was this?
A teacup.
A cup. Good. What's this one?
A knife.
And this is a...
Spoon.
Good job. What is this?
We put sand in it.
A wagon. You put sand in it. Can you say the name again? It's a...
Water with sand. With the
What's
sand.
this?
We put sand in it.
That's right.
We need a water put. We need sand.
That last clip showed examples of predictable developmental substitution errors and phonologic processes. But you also heard a number of vowel distortions, sound, and elongation of vowels in, where the elongation itself causes some distortion. These are much less frequently seen in children with more phonologic impairment, but are common in children with childhood apraxia of speech. So he provides a good example of a child we might see who has both, with the apraxia of speech being a little more mild. In the advanced workshop that we'll be doing, that some of you will likely be doing later, we'll actually have some time to practice planning treatment for children who have both phonologic impairment and childhood apraxia. If you would like to look at these samples in more detail, the Once Upon a Time Foundation also funded a set of videos for parents. I have found these particularly helpful to use with parents of the children that I have seen. There's a full video with all of the segments that runs just a little under an hour that I've put on your slide. The examples that you just saw are from segment 3, which are different levels of severity of childhood apraxia.